come up with what is comfortable for you. One thing that I'm constantly asked in many different places is, can I do this and can I do that? Can I turn my hand this way? And it's a very common question, and my answer is always the same, is as long as you can justify what it is you want to do and what it is you want to change, the answer is yes. The way I learned in school was no. Do exactly as I do, or you're going to burn in hell. I'll try and keep my commentary down. Paul jibed me about that all day yesterday during our man time. So, but I got kind of angry about things in a way, about being told to do this and do that, and the teachers really took a lot of free thought from us. Out of respect for them, I know why they did, because a lot of us were pretty stupid and we needed to be guided like little children to do things. But the problem is it doesn't really allow anybody to be great when you keep going back to the book and saying, gee, how do I do this? If you forget all about the book and you say, I want to release the occiput on the axis, if that's what the anatomy is, if that's what I want to do, then somehow I want to free up these condyles. Well, we have a lot of choices. We have choices that are not part of what we're doing this weekend. You can crack things. A lot of the old osteopaths did a lot of high velocity before they did this. Everybody thinks it's all the airy-fairy world and it's only light touch and 5 grams of pressure. I spent the better part of my year fellowship with John Upledger personally seeing patients. And of course, once I got to know John, my wife at the time knows that she needed to have spiritual transcendence with John Upledger, the man who wrote the books, everything. And I'm no more important really than any of the other billion people that are asking John's time, but he did agree to treat her. So finally, she'll get off my back. So what do you think happened? Well, she loved John. Everybody loves John. I love John. But she made one recurrent complaint. He laid her down at the table. I was not present for any of the sessions. He laid her down at the table and then he whacked her and cracked her OA really hard. So she loved all the SCR and getting in touch with her animal gods, but I got to hear all the complaints for months about her neck being sore from him cracking her. And she goes, why did he do that? You didn't tell me anything like that. I'm like, I never saw John do that, But a lot of the old people, the old guys, Dr. Sutherland, they learned from Dr. Still, soft things and bang. So, and I saw John do other things in the office that were not, you wouldn't predict these kinds of things, okay? John was more than just a CST guy, which is what he got known. I think John was one of the greatest men I've ever met, but he did a lot of very far out things. So what I'm telling you is you take your other therapies, whatever it is you understand, always the answer will be from me. If you can justify the anatomy and you want to make a little change and you feel something different, then do it. Because this process of me releasing the OA, in a couple ways I'm going to do now, this is a dynamic process. There's very little that I want to do to her. I want to do it with her. So I was shown initially to do this on fence posts, and even John used to teach this years ago, to put people up on a fence post to do an OA release. You will get an OA release that way. It's going to be more painful than doing it another way. Now I see that's sort of fallen out of favor doing that technique. But the idea being that if I lift her head up, I'm not going to do it just yet, if I lift her head up and bring my fingers rostral, meaning anterior, if I bring my fingers toward the nose, then the weight of her head back will cause it to decompress a little bit. When I'm doing it with babies, it's all you need to do. And I'm doing it with 2 fingers. All you need to do is take your fingers and push a little bit in and their nose goes up, and lean your body a little bit back and you'll start to feel pressure. The way that I do it, the best way that I do it is this way. I want to share with you as much as it occurs to my head, which some of it, Paul, is going to be off the record. So I grab women's head and men's head this way and turn it this way and bring it back this way. You know why I do that? For many, many years, I had a patient once who was a nurse, and I did something. She started making a face like this, and I'm thinking that I'm hurting her what I'm doing with the OA release. And you know what? You know what she said to me?
Pulling my hair.
You got it. Okay, so how many women's hair was I pulling for years that no one just said anything to me? They just kind of endured it. Much like the guy thought I broke his testicle. Just kind of endured it. So once she made that comment to me, I never forgot it. And I'm really careful about, I'm going to do things that for her will be uncomfortable, but I want them to be on purpose when I'm doing it, not by accident. So I'm going to hold her head as much as I can. Wherever I'm touching her, when the touch is appropriate, I'm not in any sort of challenging area, pelvis or in her mouth, I want to have as much hand contact as possible. That's not osteopathic, it's not cranial, it's just human touch. People prefer to be held as much as possible that's not challenging their emotions. My fingertips are going to go just below her nuchal ridge. Okay, so her inion is up here where my pinky is, and the nuchal ridge is just below that. Okay, here's her inion, that bump on your head that we all have, and here's her nuchal ridge, which is the end of the trapezius. Now, here's how I'm going to get the traction on her OA. That's it. Now I'm going to exaggerate. I'm just going to lean my body back. For those of you who do yoga, Tai Chi, these are some similar ideas. If I turn my body from the center, my hands follow. I turn this way, my hands follow. I pull back, my hands follow. This is a much more gentle, and you can be much more specific moving this way than you can moving like the Terminator. Maybe not the Terminator, but you get the idea. If you're just moving your extremities, it's very jerky. Okay? So I'm going to hold her hand, no airspace in my hands here in the palm. I'm not doing anything like this. You can, if you're going to ask me, you can, as long as your patient tolerates it. I'm going to move my fingers down to her feet and lift her head. Can you do more than that? Of course. The answer is between you and your patient, what you think they're able to tolerate. Now I want to decompress the occipital condyle, so how am I going to do that? I'm going to pull. I'm going to pull by leaning my body back. When I do that, the occiput initially is in 4 parts. In the adult, it's going to be all one bone. When I pull back, do you expect that to be even on the right side and the left side? There.
No.
Thank you. Okay? Nothing in life is even. People aren't the same on the right side of their body or the left side of the body. Both these condyles are not going to be the same. Someone who has a head that's compressed, when I said on some of you, I said that your sacrum felt really compressed to me. If I stay there longer, it's not the sacrum, it's parts of it that are going to be more tighter than others. It's going to be the same way here, but this is really important for me to get this release on the vault being everything that contains the brain. Okay, so I'm going to lean back initially, and one side, if I'm quiet, one side seems to give more than another. I'm going to exaggerate my body motions. If I move to the right, which side is coming loose? Yeah, you see why that is? I mean, just the nature of what my arms are doing. I'm going to pull back more on my left, but I'm going to pull back from the center of my body. When it now feels balanced to me, and the right side starts to come loose, I'm going to come the other way. You'll see me nodding a little bit in the chair. I'm exaggerating it now. But what I want to do is I want to go, it doesn't matter how I start, right, left, right. I'm going to do it again. So just relax. Okay, I'm going to go right, left, until what point?
Until it feels balanced.
Until A, her head comes off, B, some point of release that you determine. What is the end point of that release? For me, the clock is running. And I've already told you, I think if I get some release, her body can do more. It doesn't have to be perfect right now on my table. And it absolutely is time dependent. So I want to, you can try and come back together, or you can try and isolate in your mind and say, one of these might be easier to just do this one little part, and it will be easier. You come back, you come back, you come back, you come back. If you're doing it that way, what will the patient likely report to you? I don't depend on patient reports, feeling good, happy, whatever, but what is it likely they will say to you? Do you expect?
From an OA release?
Pardon me?
From an OA release?
From this, yeah. What
Feels
made it?
good.
That, they may tell you they feel this going all the way down their back. I feel something in my sacrum. I feel blah, 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 blah. And that doesn't tell me I'm doing it right. I don't look for the patient to tell me I'm doing my job right. I look for them to tell me when I'm doing something that's uncomfortable for them. But they'll get all kinds of oohs and ahs, and it just tells me I'm getting more of a dural release. If I put traction on her head, and I come underneath here and I put 10 pounds, or if we're in China, 20 kilos of traction on somebody's head, he's laughing because you know what I'm talking about, right? Yeah, they will pull your head off in China. It's part of the therapy, okay? But I saw people getting high velocity thrusting in Trendelenburg position, which is this, hyperextending the neck with a machine pulling 20 kilograms, okay, 40 pounds of traction on their head, and then hyperextending them and thrusting it. Professor Long in Guangzhou, that's what she does. And that's a treatment. That's everything. It's the antithesis of everything I was taught to do. It's the way I was taught to paralyze people. Okay, put them in Trendelenburg, hyperextend their head, and then whack and crack. But apparently a lot of people can tolerate it. If I do that, if I pull this kind of traction, what am I going to get rather than dura most likely? If I pull with 10 pounds, what's she going to pull back with?
Muscle.
Yeah, she's going to pull back with her muscles and her fascia. In that case, I may win the battle, but I'm going to lose the war. She's not going to have that feeling or that sensation of something going lower down in her body. She will if and I'm going to show you another way after this. I'm going to push her nose a little bit to the ceiling. I'm going to lean back. You saw in the video, I didn't spend too much time at all. I'm going to test my directions, left and right. It's definitely easier on the left. I'm going to pull back a little bit here. Going to pull back on the right. You can do this much longer than I'm doing. I would rather train you to be quick and then you take the luxury to be long than train you to be long and find you have a difficult time learning how to be quick. If I have the luxury, if I have an hour to treat somebody or I'm treating a friend or whatever, that's, for me it's like I got lots of time to play. So I've just trained myself to feel a release and move on. If I'm not struggling with her muscles and her fascia, then it must be something deeper in. That's my theory as to why they say, I feel this, I feel that. Some of your patients say they feel this and they feel that. I don't know what they feel. They're just crazy. So the moment you touch them, they're, one step from an orgasm. You don't know what's really happening with them. But a lot of people that are, that are not in love with your treatment, they don't know anything about you, they've never had body work done, they make the same comments. Oh, I feel something in my back, I feel something in my sacrum. And they're not somebody who's been pre-prepared to love you before they got on the table. You can only have that feeling if you're not fighting with the muscles.
What if in some of your more extreme cases when you don't really feel a release?
Then I just do it for a period of time and then I move on to something else. You will see me, I want to show you some other things this weekend. You'll see me do something here and then move on and then come back to it. And in most patients, most of the time, I'm going between OA and sacrum several times. There's another kid that I want to show you, another 7-minute video. If I don't get what I want, there's a certain amount of time where I go, all right, I need to spend my time doing something else. I don't get stuck with this goal must be achieved or the whole treatment's not going to work. I might repeat and come back to it in the same session, or try and do another type of technique and see if that releases something. Okay, sir, would you come up? CK? Is that CK?
Yes.
What is your true name?
Psyche.
Psyche, okay. And my friend in the tape is CY, but that's not his name either. Slide down. Okay, you can see my hand is going to completely touch his head. I can lift him up or I can push my hands a little forward. I like to do everything with center body movements. I find how far do I lift his nose to the ceiling? It's my choice where I feel I'm getting some tension but not too much. Now I'm going to lean back. When I lean back, left and right feel the same to me. I'm going to lean back a little bit more. Still feels the same, so I'm going to just play. I'm going to move to the left. Not too bad. Move to the right, doesn't want to come, so I'm going to just lift up his left side. Whatever I lift up, I'm going to keep as I go back and back and back. I'm not massaging. And massage for me is not a dirty word. Massage to me is I'm going back and forth over the same area, trying to loosen something up. I'm keeping cumulative tension on his OA. This has nothing to do with rhythm at all. You can do the vault hold, and we're going to do all the diagnosis and say, well, the first thing you're going to feel with a head that is very tight or misshapen is it won't feel right to you. You're not going to get very specific. My teachers told me, put their hands on the head and they knew it was X, Y, and Z disease. No, I don't think so. You put your hands on the head and you go, this feels like a stone. Let's just start with there. It doesn't feel right. Then you go through the individual bones and you can say, this moves, that doesn't move. It's very easy. You don't have to be a wizard from the moment you see them in the door. We had one teacher who was the wizard in class. Looked at you. You have a left rib your left rib floor is out, and then he would lay us down in front of 200 people, and he would prove it by touching tender points. So he would lightly touch on the person he didn't want it to hurt, and the person he did want it to hurt, he would take his finger and drill it through the table until you were squealing. You know, I know how the shell game's played. The shell game doesn't work when it's with patients who are paying you money. That's the problem. It works when you're a student in class, and class is a captive audience. When you get that kid and they say, is there something you can do for my kid? All bets are off. You free up restriction where you feel it. I'm going back and forth. This is nothing waiting for the cranial rhythm. I can always just stop and decide to wait for cranial rhythm. I can stop and do CV4. Mobility you'll do in the time that you saw on that tape. And briefly I evaluate his cranial rhythm while I'm doing mobility. But if I don't free up mobility, that kid's head doesn't move. How's that? Feeling the flow?
Yes.
Okay. So what I want you to do is, actually, let's do this first. Let's add one thing to it. Just before you do anything, stop for a minute, since we're doing the rhythm, and see if you can become aware. Just relax your thumbs, not a volt hold, just holding the occiput. What should be the motion for flexion and extension? Flexion, if I exaggerate, is going to be some pressure into the table. Extension, if I exaggerate, is going to be the change in that. Paul and I had a funny conversation actually yesterday about, you were saying you felt flexion much more than extension. And my sarcastic, smart-ass comment to him was, if you're feeling flexion, it must be going on to extension in between the other feelings that you're having. So it doesn't just continue to go into flexion. It's just your body becomes aware of other things. So if you're aware of only, you feel pressure into the table, there'll be a point at which you don't feel pressure into the table. Okay, and I'm exaggerating by pushing my hands. You don't need to move your hands. You need to do nothing. So you can compare that sensation, how big it feels before you do it. Do an occipital release. Come back and compare the sensation afterwards. Do not cheat yourself and think that you have to feel this or you have to feel that. I don't want to come around and say, do you feel this? It's just embarrassing you into pulling you completely out of the moment. And there is only you and your patient. That's all there ever will be. Hopefully. You know, you can call me and tell me about it later, but it's just going to be psychological help for you. Okay? So do this first, and then I want to show you another way. And I want to show you another way that I sort of came up with problems that I had. So try with somebody on the table and someone in the chair.